Welcome to the Healthcare Unfiltered Express, where I conduct short video interviews packed with relevant and timely information that you cannot miss. So sit back and enjoy the show. Folks, you know how it is. It's Healthcare Unfiltered Express. It's a major meeting, and after each major meeting, Vivek Stakes, and Vivek Stakes on ESMO 2025. And for those who are listening, it is very rare that we catch Dr. Vivek Subbiah on the ground. He is usually trains, buses, taxis, planes. But Vivek, it seems like you are on the ground and in your office today.
Yes, absolutely. Just got done with clinic, and I'm here. So again, for the broad audience here, thank you so much for having me, Shadi, in your podcast.
Welcome, my friend. So, you gave so many talks at ESMO. I attended 2 of them, and I know you probably gave 4 or 5. But we are going to talk about the tumor-agnostic session that you actually gave, because I think that was very unique, very different. But before we go there, we have my viewers and listeners have grown accustomed to listen and hear you talk about your takes after each major meetings, the ESMOs of the world and the ASCOs of the world. So what are your top takes? What did you see at this ESMO?
Again, for all our listeners, ESMO Congress was from October 17th to 21st in Berlin. And again, the convention center was unique because it was one of the most challenging convention centers to navigate.
It was.
But, if one can navigate the convention center, I think one can cure cancer. Again, highlighted numerous advances in developmental therapeutics, early phase trials, novel agents, precision strategies across tumor types. I would say, as always, I think this is the best time to be an oncology drug developer. Again, we had so many updates from antibody drug conjugates, targeted small molecules, radioligands, immunotherapies, biomarker-driven approaches. Again, so much data to go through. And it was like, feeding from a fire hose. And again, I can talk to you about what I can just think through in my mind, about all the updates here. I think it was a theme of antibody drug conjugates. Again, a lot of top 1 payload-based antibody drug conjugates now with clinical data. Again, we had many in clinical trials, and then in early development with data. Again, the first one up is, they call it TMAB-A, telisotuzumab adesotecan. Again, this is, it was previously known as ABBV400. And this is a next generation c-Met-directed antibody drug conjugate with a top 1 inhibitor payload. A phase 1 basket study was done that showed c-Met amplified tumors, again, over 40% to 46% confirmed objective responses across many tumor types. Interestingly, the same drug was also presented with a pancreatic cancer cohort. Again, it was a pancreatic cancer cohort, an all-comer pancreatic cancer cohort, and that also showed, terrific responses with this TMAB-A. Interestingly, the PDAC cohort consisted of 42 patients with pancreatic cancer, with a median of 1 line of therapy. And interestingly, almost all the patients, again, 90% of the patients had c-Met protein expression, and the confirmed objective response rate was 24% across all the pancreatic cancer participants. So again, this agent, it has activity beyond pancreatic and all other cancers. It has activity in colorectal cancer, lung cancer. And I think this agent is also being tested in a tumor-agnostic manner. And I think this will be definitely, hopefully, a tumor-agnostic drug at some point with multiple indications. So again, this is one ADC. The next ADC is called Izabren. For everyone is calling Izabren, but it is Izanlatamab bringitecan. Again, it's a top 1 payload. It was called BO1D1. It's specifically an EGFR HER3 bispecific antibody drug conjugate, and it showed activity in nasopharyngeal carcinoma. Again, it also showed activity in non-small cell lung cancer, and that was interesting. And there was another drug, antibody drug conjugate, folate receptor alpha, AZD5335 from AZ, targeted ADC. Again, the name of the trial was Fontana trial. It showed activity in platinum-resistant ovarian cancer. And interestingly, there is another HER2 ADC. It's called disitamab vedotin. Again, it was a phase 2 distinct study in urothelial cancer. Again, showing R0 improved resection rates with this combination with tislelizumab combination. And again, another ADC, a novel first-in-class ADC called IB6-directed ADC. It's called Sigvo Tatug vedotin. Right. So again, it's for oncologists. I think we should be all good at spelling bees, remembering all these names. Biomarker analysis showed that 65% of non-small cell lung cancer would respond to this, type of therapy. Again, these were some of the antibody drug conjugates that were presented. Also, early phase, there was a MUC1 antibody drug conjugate that showed activity across many tumor types, especially GI cancer tumor types. What about small molecules?
Lots of ADCs, though.
Lots of ADCs.
Is it just because they're easily manufactured, easily done? Is that what you think? I mean, what? Like so many.
Again, I had someone count. We have 875 ADCs in different clinical trials. And again, I think we have 17 ADCs approved. Again, ADCs, as you know, Shadi, are chemo. Like, again, packaged payload chemo, targeted chemos, right? It's like, think about, this is how I tell my patients, right? Chemotherapy is like a carpet bomb, right? It wipes off everything. But antibody drug conjugates, it's like a guided missile, like a bunker buster bomb, like a guided drone that directs this antibody, directs this drug conjugate to exactly where the tumor is. I think we have better technologies. I think with trastuzumab deruxtecan, Enhertu technology, and EV Pembro being standard of care in urothelial cancer, bladder cancer, shattering the standard of care therapies frontline. I think there are more and more ADCs, and also we are developing better to best-in-class ADCs. We have better designing better drugs. We are looking also target expression as well across multiple tumors. And I think, more and more ADCs are coming. I think it's, it'll be interesting to see how this area pans out within the next 2-3 years.
Before we get into tumor agnostic thing, what were your thoughts about the world of CTDNA from ESMO? What have you seen in liquid biopsies, MRDs, and in that area, I guess, at ESMO?
Again, CTDNA, there were multiple abstracts presented on liquid biopsy. And again, liquid biopsies are tumor agnostic, right? They've shown activity. They've shown liquid biopsies have been shown in colorectal cancer. Again, most of the studies were in colorectal cancer. Now, this ESMO showed in bladder cancer in the earlier and earlier setting, in MRD settings as well, right? Both quantitative and qualitative analysis. And also, liquid biopsy is being used for response assessment, right? RECIST is a crude measurement in solid tumors. And, we have a new addition to RECIST called LB-RECIST, liquid biopsy-based RECIST, that is emerging, right? That's been validated only in colorectal cancer. And for the listeners, this is available. This liquid biopsy criteria is available. I think it should be validated across multiple tumor types or enhanced. Again, the first liquid biopsy-based criteria is out, but I think it needs a lot of enhancements, amendments, and modifications for different tumor types. And that idea and that data has been discussed in extensive detail in ESMO meeting. Again, we are still scratching the surface of liquid biopsy, CTDNA, CFDNA, and I think we'll be seeing more and more on that in the near future.
One of the highlights of the meeting is you discussing tumor agnostic therapy. And how did this session come about? First of all, I don't think we've seen similar session, at least at ESMO. I don't know if this is a new trend. It's going to be at ASCO or something like that. But maybe give us a little bit of the background on this. And then what did you talk about? What was your presentation about? What was the session about? What was the goal?
Oh, absolutely. Thank you so much for asking that. So ESMO this year, 2025, again, the ESMO president and the scientific chairs, the ESMO president, Dr. Fabrice Andre, the scientific co-chairs, our beloved Dr. Tony Shuri, and our amazing Dr. Mariam Shalabi, got together and came up with three different new tracks for any major meeting, right? For any major meeting. The first track was tumor-agnostic track. The second track was, of course, separate AI track. And the third track was cancer prevention. So again, it was a pleasure and honor for me to chair the first ever tumor-agnostic or tissue-agnostic track, marking a milestone in big conferences and precision oncology. So this track essentially emphasized shifting from organ-specific to biomarker-driven treatments. We are used to doing drug development for breast cancer, colon cancer, lung cancer, brain cancer, etc. And a tumor-agnostic drug or a tumor-agnostic drug development or tumor-agnostic therapy is a different way we think about cancers, focusing on the target, focusing on the molecular driver, right, which represents a transformative shift, focusing on the molecular characteristic of the tumors rather than their anatomical origin. So 2017 was a watershed milestone moment in oncology when pembrolizumab, an immunotherapy, was approved for a genomic biomarker for MSI-high cancer. So since 2017, we've had now 10 tumor-agnostic drugs approved, right, from NTRK fusions, not one, but 3 drugs approved for NTRK fusions, a BRAF and MEK combination approved for BRAF V600 mutations, 2 drugs approved for dMMR and MSI-high cancers. For TMB high cancers, immunotherapy, RET fusions, we have a RET inhibitor. And of course, we talk about ADCs. Trastuzumab deruxtecan is approved now for all cancers overexpressing HER2 by immunohistochemistry 3+. So this offers hope to patients with rare or refractory cancers who may lack standard options. So again, FDA has approved such therapies based on compelling data from non-randomized studies. However, the real-world implementation challenges reveals only 1/3 of eligible patients with NTRK fusions, rare fusions, receive this appropriate treatment, highlighting gaps in genomic testing and education. So I think these sessions will hopefully educate and create awareness for general oncologists, right? So again, the reason why I think we have, first they said we cannot pick these needles in haystacks like NTRK fusions. But now we are picking these needles in haystacks, but we are not threading this needle in. That is matching the patient to the right treatment option, right? The gaps are in genomic testing. Okay, well, we did the genomic test, but we don't match the patient, right? Because of clinical awareness. And beyond the US, there is not much regulatory adoption in many countries, especially the LMICs of these tumor-agnostic drugs, because these are single-arm studies. So these sessions, right, specifically the tissue-agnostic track, of course, we had a lot of abstracts presented, but the tissue-agnostic track was a special symposium on Monday prime time and also a special educational session, 2 sessions dedicated for tumor-agnostic therapies. The first session on Saturday was tumor-agnostic anti-cancer therapies, ready for prime time. We had 3 amazing colleagues from Australia, again, Dr. Jenny Liu from Australia, Dr. Neve Coleman from Ireland, and Dr. Juliana Bill from Brazil, presenting on tumor-agnostic anti-cancer therapies ready for prime time in that session. And the prime time session on Monday was accelerating tumor-agnostic therapies. And I presented my perspective from the clinician point of view, why we need to have a molecular reclassification of cancer and also tumor-agnostic therapies. From the pathology point of view, Dr. Fernando Lopez-Rios from Madrid presented his take as a pathologist and why we need to accelerate tumor-agnostic therapies. From the statistician point of view, Dr. Stephen Michaels from Gustav Rossi presented his take from the statistical perspective. Most importantly, we have a regulator from the EMA, Francisco Pignati, presenting on what it takes for EMA or a regulator to approve a tumor-agnostic drug. So again, we discussed trial designs, the evidence gaps, approvals on these 2 special sessions. And one of the important things that came out from this session was cancer discovery publication. Again, I wrote my personal perspective. Again, personal perspective does not reflect ESMO or organization or any institution as a drug developer on why we need tumor-agnostic therapies and rethinking drug development through the lens of tumor-agnostic drug development. Again, this talks about how we need to design studies, the regulatory challenges, the real-world implementation, and how we can classify cancer based on the ESMO tumor-agnostic classifier and screener. Again, we need validation and molecular-guided therapies across tumor types. Again, we are still scratching the surface. And what my personal call for this is right now we have 10 tumor-agnostic therapies. Over the next 25 to 50 years, it's a challenge for all the oncologists, oncology drug developers, pharma, industry, regulators, patients, and patient advocates. My pitch is that we need to have 50 to 100 drugs approved based on molecular biomarkers in a histology-agnostic space. That is the only way we can move the cancer needle forward. Thank you so much.
I don't think there are any, I think part of me is, you may be shocked what I'm going to say, but we have done tumor-agnostic therapies all the time.
Yes.
Taxol,
yes.
50-year, 5-FU.
Absolutely.
Essentially, we have used chemotherapy in various tumor types. 5-FU was used in breast cancer, colon cancer, rectal, and so on.
Absolutely.
So the approach of tumor-agnostic therapy with the same drug works across these diseases, has been there. I think what's making a huge difference is now you have an actual target.
Yes.
So I like the idea of creating these new drugs. The question always goes to going in the lab, how easy to create that chemical structure and the actual molecule that targets the specific target, how easy to find that target. But maybe my last question to you, though, is that if you do these tumor-agnostic therapies, how do you factor in the role of the microenvironment that is really more specific for that tumor? I get the target. I understand. You could have a target across 10 diseases, and if you have the target, you use the drug. But are we saying that the microenvironment of each particular tumor is not as important as the target itself for this tumor-agnostic approach to move forward?
Thank you so much for the great question. I think, if hallmarks of cancer are tumor-agnostic, right? All the hallmarks of cancer, think about that. They are not focused on one particular cancer, they are tumor-agnostic. And for us, every target, if there is a target, it is a pan target, right? I think the useful context is, it does not imply universal, uniform responses across tumor types.
That's because of the microenvironment then.
Because of the anatomical accident.
Yeah.
Again, let's take, for instance, BRAF. BRAF is a tissue-agnostic target. It's a pan-cancer target. All other cancers, you need BRAF and MEK. In colorectal cancer, BRAF is still actionable, but in that cancer, you need BRAF plus EGFR. So we have approved therapies in all cancers using BRAF and MEK. And in colorectal cancer, we have an approved therapy with BRAF and EGFR. That doesn't make it not a tissue-agnostic target. So it is a tissue-agnostic target. In this particular exception, for colorectal cancer, it needed EGFR inhibition. That's about it. So that is why one of the most important things that ESMO has put together is this ESMO ETAC tumor-agnostic classifier and screener. Again, this is called ESMO tumor-agnostic classifier and screener, which standardizes validation for molecularly guided therapies across tumor types and gives us a roadmap on how drugs should be developed. Again, it's mainly useful for pharma companies, academia, on how to develop drugs. It proposes a framework for how we should view targets for drug development, right? I think we are losing a lot of patients. We are losing a lot of drugs. Many people and patients are being denied access to drugs because of where the tumor is. Because we are developing drugs based on histology, not based on molecular profiles. Think about it. A patient with salivary gland cancer with BRAF mutation won't have a trial done for that patient unless if the drug is approved in a histology agnostic manner, right? The drug, take for instance BRAF. Again, I come to BRAF because it's close to my heart. Melanoma, it was approved in 2013. Tumor agnostic for brain tumor, cholangiocarcinoma, all other cancers. It was approved only in 2022. So a patient sitting in New Mexico, Montana, North Dakota, had to wait for 10 years. Same molecular alteration, BRAF right? So this leads to what I call it as molecular inequity.
That is a good point.
Just because the tumor is sitting in a different location, that patient did not have access to therapy. So these molecular inequities, therapeutic inequities, will be addressed by tumor-agnostic drug development. That is the only way to move forward.
Well, and you are doing so. You are moving the field forward, my friend. We are all proud with everything that you're doing, and thank you so much. Congratulations on a great meeting, great talks, and for folks who are listening, please take a listen to the ESMO on demand. A lot of these talks are still there. Dr. Vivek Subbiah, tumor-agnostic baklava or tumors. We talked about that, Petros and I, when we had them on the show.
Absolutely. Yeah. No, again, again, baklava is great. Recently, as I mentioned, I had a Dubai chocolate baklava, and I think everyone denies that it cannot be a baklava. It's a chocolate. They say it's a chocolate. It's not a baklava.
They put ice cream on it.
They put ice cream on it.
Yeah, exactly.
Dubai chocolate baklava.
It's literally everything that you should not be eating right there. Well, thank you so much for coming on the show. Thank you for listening to this edition of the Healthcare Unfiltered Express. Until next time, take care.